tracking to be more, it's a mass casualty event in the United States and globally, more lives lost than lost in any American battle other than World War II or the Civil War. How it is tracking even within 2020 to be the third leading cause of death behind heart disease and cancer. So that's that fast pandemic. But when I talk to you about the slow pandemic, I'm talking about systemic racism. And I'm talking about what has been in the root, in the soil of this nation, and the forming of this nation for over 400 years. And it's the collision course of those two pandemics that has worsened the outcomes in Black and Brown communities. You're speaking with a Black woman physician. I am a public health physician. I'm a hospital administrator at University Hospital in Newark, New Jersey. Rutgers, New Jersey Medical School also is one of the sites where the Moderna COVID-19 vaccine trial has been sponsored. I've seen that devastation up close. So when I say roughly 1 in 875 Blacks has died because of COVID-19, that's the type of destruction I'm describing. When I say 1 in 925 Indigenous Americans have died, that's a destruction I'm describing. 1 in 1275 Latinos or Latinx have died. That's the devastation that I'm talking about. And we can never lose sight of that health equity lens, because while this has been widespread and unprecedented damage and devastation, Black and Brown bodies are bearing the brunt of this disproportionately.
Thank you for saying all of that. And we sometimes in public health, we talk about, these communities are more disproportionately impacted, but it's not just because of our skin or our culture. Can you talk about some of the social determinants of health? Both of you or anyone who's on the call, to speak to some of the social determinants of health, like what are the factors that cause Black and Brown and Latinx and Native folks to be more impacted by these viruses than just, our citizens, our fellows, our neighbors who are white?
I can start and then I'll just yield the floor to anyone else who'd like to add in. I think it's best to start here with two different frameworks. One, to ensure that everyone understands what health equity is. If you use the definition that the American Public Health Association uses, the APHA, so think about health equity as the ability of every person to achieve their highest level of health, every person. Right? So there are barriers in place that make the achievement of health equity less likely for certain racial and ethnic groups. Dr. Cameron Jones, who is a pantheon in the field and a past president of APHA, actually describes social determinants of equity, those political forces, those systemic forces, those cultural forces like racism, like sexism, like classism and economic vulnerability and disenfranchisement that affect the distribution of the social determinants of health. Okay, so when I say the social determinants of health, I'm talking about where we live, where we work, where we pray, where we worship, where we learn, and where we are born. Those factors actually predispose groups and persons to different life exposures and hence different health outcomes. It is not that there is something biologically inherently different about Black and Brown bodies. You'll see science flirting with that notion, but right now there's a huge push, even in the A.M.E, American Medical Association, to really challenge physician and physician scientists around race-based medicine. It's more so usually geographical differences, and those geographical differences are rooted in those social determinants of health. So there have been studies, and if you look at US Census Tract data, Black and Browns, we comprise upwards of 43% of the service and production industry jobs. So we work those frontline essential jobs that increase our exposure to an infectious agent like coronavirus. Those jobs are usually lower wages. Those jobs usually have less income protections. Those jobs usually don't offer hazard pay. The effect of those realities means that those people are less likely to work from home. Those people are less likely to have access to protections and provisions that would shield them and thereby reduce their exposure. Hence, my sister, a breast cancer survivor, and had been working at a large retail chain as a customer service manager and worker, and got exposed to coronavirus, most likely at her job, interfacing the public. So we work in those industries. We live in cramped and crowded housing more often which is a legacy of racial residential segregation. And when I say racial residential segregation, I'm talking about the impacts of systemic racism and redlining, where Black and Browns are more likely to be situated in substandard housing and in cramped and crowded housing. So if you have one person who has been exposed, it increases the risk that it will move throughout your household quicker, because you just have more, you're more confined. You're less able to practice physical distancing and less able to practice safe quarantining. Black and Browns are saddled with more comorbidities. So then it makes me think of my father, who I lost to this pandemic. My father, a Black man who survived the Jim Crow South. I like to talk about what he survived to give people a good dichotomy and a comparison. My father, 78 years old when he died on April 13th because of this pandemic, who survived the Jim Crow South. My father, who survived HIV/AIDS, who was diagnosed in 1997 and pretty much had an undetectable viral load because of superb care for at least 10 plus, 12 plus years. My father, who was surviving COPD, who was surviving end-stage lymphoma, who had gone into the hospital for some other reason, which was not related to coronavirus, and waiting for placement in subacute rehab, got exposed and ultimately died in a matter of 10 days to 14 days. So Black and Browns have those risk factors. And the last thing I'll say before passing it was some years ago, when we talk about Blacks having higher incidence or higher prevalence of high blood pressure, or higher prevalence of diabetes, or higher prevalence of some of these other chronic conditions, higher prevalence of overweight or obesity, racism is a pre-existing condition.
Yes.
Because racism structures access to clean air, access to education, access to a living wage, access to the things that are protective in health. Mm-hmm. And so I'll leave it there. I've said a lot, but I'll leave it there for the conversation. So thanks, Sue.
No, don't leave it there. That was too good. Don't leave it there. Stay there.
Okay, great.
Oh, there's still more to come. Dr. Kalani, do you want to talk about how those social determinants of health or equity are impacted by or included in the research process?
So I think she has said it really beautifully as to what the social determinants are. And unfortunately, based on those social determinants, it leads to inequalities and delivery of care. It leads to the barriers of accessing care. It leads to the barriers of getting to the research facilities to access those cares. Unfortunately, there's a long list of issues that have gone back related to our to the Black and Brown community not being able to believe or trust in our medical system. But unfortunately, I actually just had a conversation with my HIV patient, who was my long-term patient for more than 20 years, who is Black by race. And I actually talked to her about, coming into this vaccine that I am a PI of, and it's available here at Hackensack. And she says, oh, I don't think so. What if they don't give me the vaccine? So it is the distrust in the system that does come into play, unfortunately, based upon their long-term issues related to healthcare. Now, my only thought process, what I actually told her in one person was, hey, if you don't step up, how am I going to break this inequality? How am I going to get this inequality away? How am I going to be able to help be at par with what you have with the white community or with any other community in that particular matter? With research and science, when we say, okay, this particular vaccine is going to be available, how am I going to be 100% sure that it has the same efficacy that it does in a white person versus a Black person versus a brown person if you don't step up and be a part of it? So a research is an opportunity to try and help get this particular inequality a little bit fader, a little bit slower, a little bit taken away from this particular area. It gives us an opportunity to hopefully have access to care, get them engaged into the access of care by getting into this particular team. So for example, with this particular vaccine trial, by the by the scientific teams that they have been there, they've actually asked us to make sure that there is an X amount of percentage of patients are across the board with different racial backgrounds so that we are able to get good information on the same phenomena of efficacy and of safety in each and every modality, in each and every portion of these patients that are being negatively impacted. Having said that, yes, the trials did a good job, or at least did a better job, I should say, than what has been prior done, but it's still not to par as to what we would have liked it to be. Part of this, again, comes through the faith in trusting this particular field of medicine and saying that, what is going to be given to me is going to be the same as what's going to be given to somebody else. And that kind of help and the misinformation or the mistrust that we have is unfortunately showing its mark. Thankfully not as much in these trials, but still not at par, unfortunately.
Can I weigh in on that?
Oh, please.
Okay, so Dr. Villani said such great things that I think it's important for us to drill down on. So we're seeing at this point in our history unprecedented skepticism around the broader public health infrastructure. There's skepticism around our public institutions because of disinformation and misinformation, right? So even across the US population, the levels of skepticism are at an all-time high. When you drill down and look at Black and Brown communities and look at the Black community in particular, there is a legacy of racist medical practices, abuses, a legacy of medical experimentation and exploitation that has caused a collective psyche, a collective trauma to the Black psyche. And I think it's important that we drill down on that exactly, because I've written about this, I've spoken about this. Look, I'm a Black woman. I wake up and go to bed with the same realities that so many folks in my community face. And I wrote in a piece that too often science has been a tool of white supremacy. There's no other way to say it. And because science has been a tool of white supremacy, it is hard for there to be an unfettered, for there to be a healthy and an effective relationship between Black and Brown communities in the academic medical complex, in public health in general. You can just go back to slavery and how enslaved Black women were subjected to gynecological surgeries without anesthesia, without their consent. You could think about Tuskegee, probably the most well-known and the most famous Black men, lots of them veterans with syphilis, with treatment knowingly being withheld in order to understand the natural progression of the disease. I could talk about how Black bodies were robbed from cemeteries so that students in an anatomy class could learn the anatomical differences of human bodies. I could talk about Henrietta Lacks, a Black woman in segregated Baltimore who had metastatic cervical cancer and had tissue taken from her womb without her knowledge. And that cell line went on to become one of the most productive cell lines ever, by which a host of discoveries across infectious diseases and cancer have been made. I could talk about Mississippi appendectomies, where Black and Brown women were forced to undergo sterilization under the guise of something else. That collective racist medical experimentation, exploitation, in addition to the ongoing disparities that we see, ongoing. So we not only have a history of trauma, we have ongoing disparities. I could talk about implicit bias and how implicit bias impacts provider and patient relationships, where even as recent as 2016, if you asked medical students in a very small study, do Black people sense pain differently? They said yes, because they thought the thickness of our skin was different, so that we didn't sense pain the same, or how different interventions are recommended at disproportionate rates for Black and Brown groups. It is not until we in medicine, we in healthcare can center the dialogue. We have to be able to acknowledge that. Dr. Cameron Jones also says that as long as we practice healthcare and medicine from an ahistorical perspective, we only perpetuate whatever the history has done. And I think now is an opportunity for us to, I've been having that transparent dialogue because people will frankly ask me, you as a Black woman, do you trust this? Are you going to do this? Don't you know what happened to our people? So it's important that I address that head on and to say, yes, I do know what has happened to our people. And yes, I do know what still happens around disparities. Have we made changes in clinical research? You bet you. We have had more robust guidelines, more robust ethical guidelines, informed consent. But do we still miss it? Yes. And as Dr. Balani was saying, the flip side of that inequity coin is that if Black and brown persons don't participate in clinical research, it only perpetuates the inequity. It doesn't improve it. So I share with people that I enrolled. I enrolled because, you know, this was my way of being a part of the solution as a public health physician, but that might not be the right choice for everyone else. So I don't pressure people to say, look, you need to enroll, but I say, I need you to understand why this is an important opportunity and why it's important for our people and all people to have access to it. And especially if you hear disinformation, I need you to stop the disinformation so that we can get the facts uplifted and elevated, because ultimately the trial is to put us in a position that we have an effective candidate. We have several candidates out the gate, Pfizer and Moderna, talking about game-changing levels of efficacy, 95%. We haven't seen that before. But if people don't trust, they're not going to take the vaccine, and it's not going to be the solution that we would hope it to be.
I agree.
Such rich conversation. I don't want to overlook Reverend Bird, I'm sorry, I don't know why I do that. Reverend Bird, as we talk about community and we talk about faith, I realize we're talking about faith in two different senses. We're talking about faith in the medical process, the medical institution and research industry, but also spiritual faith and faith in God. Can you talk about how your congregation and the community of Harlem have been impacted from your perspective as a faith leader, as a community leader by coronavirus and COVID-19?
Well, anytime that level of brilliance is sharing necessary information, you can overlook me anytime. I welcome it. Allow me to say a couple of things, and I want to welcome all of our panelists and thank all of you very deeply on behalf of our congregation for being with us today. We know that it is God, it is Yahweh who has extended the cords of our existence and has allowed us to see another day. We are all in our nature pavement level people with hands and feet of protoplasm. We are formed, made out of clay. We're pavement level people, pavement level dwellers. And a lot of things happen at pavement level. Over the course of our congregation's 200 plus years of existence, we can trace our history back to 1774. This congregation has survived 4 pandemics in our history and our heritage. Everyone talks about 1918, but there were so many others. There were others in the 19th century as well that our congregation has survived. We could literally write a book on how faith communities can triumph in the midst of epic pandemics such as this that wreak havoc not only at pavement level, but for pavement level people with clay flesh that have been kissed intentionally by the sun by way of heaven. We know without question that communities such as Harlem and the South Bronx, Newark, places out on Long Island where I served for some years, Hempstead, were incredibly affected by this dreadful pandemic. It hit Mother A.M.E. Zion Church in a big way. And it hit in such a way when there were individuals in our nation who were still really unsure what was happening in New York, but New Yorkers were dying big time. And because we were in many respects ground zero for this pandemic, we were dying when people were still trying to figure out what was killing us. And the most unfortunate, one of the most unfortunate effects of COVID-19 for pavement level people who have known their fair share of marginalization is that due to the necessary restrictions around assembly, our burial customs, our grief customs were removed from us out of a necessity. We all knew of the importance of keeping a safe distance, quarantining when necessary, not assembling in great numbers. But burial customs from a Black Christian perspective is actually West African burial customs. These customs made its way onto slave ships, and we buried our loved ones here in soil that would never belong to us, according in many respects to West African burial customs. We were not able to do that this time. I stood in cemeteries to bury members of Mother A.M.E. Zion Church when only myself and the grave diggers and the undertakers were allowed to the grave site. And so you talk about psychological bruising that Dr. Purnell just shared with us in a great way regarding having to keep your head and to remain proud when for many years, scientifically, we were the primary guinea pigs. There's another psychological bruising that is developing from this, and that is the effects of having to mourn while still in transit, not having the opportunity to pause long enough to mourn deeply for those who have meant so very much to us. It's going to take years for us to be able to work through grief and bereavement in transit and at a distance. Not only were we not permitted to bury our loved ones, we weren't even able to hold their hands as they took their last breaths. Clergy persons we were given the designation as essential workers here in New York after we had already buried half of our congregations. We were not permitted, for justifiable reasons, to be with our loved ones as they transitioned from one world to the next. And so that has informed, in many respects, from a Black Christian perspective here in Harlem, how we look at what church looks like at pavement level in the future. How is it that I, as a religious leader now focus more of my attention on what the church looks independent of the stained glass and the brick and mortar than it does when we view church as what we did inside of a consecrated space with a pipe organ in a climate controlled space, rather than how the church can also be in transit to provide the type of healing that our community needs in mind, body, and spirit, as we are all attempting to emerge from this as a phoenix rising essentially from the ashes. And so that has really been where we have been lately. But this chapter is still being written. The community of Central Harlem banded together in ways like I had never seen before. You had the World Central Kitchen and Reverend Al Sharpton and the National Action Network distributed more than 1 million meals between Central Harlem, Newark, and Detroit, and other marginalized communities. You had churches here in Central Harlem setting up food for people had been furloughed, who had lost their jobs, who were still able to stay in their homes because of edicts by the government and local officials, but they were food insecure. You have a place to lay your head, but do you have anything to eat? And so this really gave the church an opportunity to really do what we believe to be the real bidding of Jesus at pavement level, and that is to do the work of the kingdom that doesn't always factor into passing out tracts or parochializing the faith, but it really means sharing love. What is justice? Justice is love at pavement level. And that is what I have seen here at pavement level from our religious communities who have been seeking to make a difference in the midst of this. We have all lost so very much in the midst of this, but here is what we have learned. We really still have each other. And we have been more committed to lean together, lean on each other independent of denominational lines, because we realize that COVID-19 is not a Baptist. It's not a Methodist. It's not non-denominational. Mm-hmm. You know, COVID-19 has affected all of us. Yeah. And it is because it has affected all of us, we all must commit ourselves to do whatever we must do to hold our communities together and to ensure healing as a community together, one way or another. Thank you.
Speaking about what we can do to bring about healing in our communities, Dr. Purnell, even though you're a doctor, you're a researcher, you're a public health official, you've also chosen to invest yourself in the research process as a participant. Can you tell us how you made that decision and what the experience has been for you as a participant in one of the clinical trials for COVID-19?
Sure. So I started to talk a little bit about this in my earlier response. I am also a woman of faith. I am also ordained. An apostle with Bet Hashem Yahweh Worldwide Ministries under Bishop Purnell here in New Jersey. And my father and my father's father and my mother's father come from strong tradition of faith. My father's father, the late Bishop Apostle John W. Purnell, and the apostolic movement, the late Reverend Harrison Gregory, who was a Baptist minister who taught me the principles of faith in action. Mm-hmm. And knowing those principles of faith in action, I needed a way to deploy my faith that things could get better in the midst of darkness and despair. And so I just lost my father on April 13th. I told you my sister, the week that we buried my father. So we had some delay because as Reverend Burt was describing, the grieving process has been surreal because the grieving process has been affected by the pandemic as well. Access to, my father, I worked 4 miles away from the hospital where my father died. And I was trying to race to get there before he passed because I was going to be given access to him. And he died as soon as I got to the parking lot. So I needed a way to pay forward goodness. I needed a way to pay forward a solution. I saw the despair in my community in Newark, New Jersey, where coronavirus it wasn't the only thing that killed people by being infected with it. Coronavirus also had people shun the healthcare setting. So we know during that time that our dead on arrival EMS runs spiked by 200%. We know that we saw less heart attacks and less strokes in our emergency department at University Hospital. And that wasn't because people weren't having heart attacks or strokes. That was because they weren't making it to the hospital. So knowing all of that and being in the midst of all of that, I needed a way to be a part of the solution. And my father, a research scientist, my father has a brilliant story. A Black man out of the Jim Crow South comes north. Ultimately, my father starts working at the famed Bell Labs in Murray Hill. He starts on the grounds crew. My father goes from cutting grass to being a research scientist at a level that is usually reserved for those with PhD degrees. So I lived in a household with a man who very much knew about action, who believed in science, and who looked for opportunity to make sure those behind him and those within community had access to that. So that all of that was the motivation for me to participate. And of course I got questions. People say, are you sure you want to do this? Are you sure it's safe? And Dr. Balani can tell you what we knew at that point. I knew what was published from phase 1 data. I knew that there had been no serious medical events from the phase 2 trial, which was literally ongoing, right? Because typically in these clinical trials, phase 2 would have closed before we would progress to phase 3. But because there was a need to get at a solution quicker, those processes were simultaneous or overlapped in some way. And so I knew that there had been no serious medical or adverse event. And I prayed. I'm a praying woman. I'm not ashamed to say I'm a woman of faith here today. And I felt led that this was the way for me to show up. This was the way for me to share power. And sharing power is either your knowledge, sharing power is either opportunity or access. So I enrolled. And my experience to date, and I think it's important for people to understand this, my experience overall has been a very good experience. The study team was very clear and very consistent about walking me through the process, explaining the trial, explaining the science. I knew full well that it was voluntary, and I want to emphasize that for anyone who may be listening, that I could withdraw at any point without any punitive measures. I could say, I want to withdraw. Either I'm withdrawing because I had some type of side effect or some other reason. I could withdraw at any point. So informed consent, which is sacred, and which had been abused in the past, was definitely upheld through this trial. So this was my way of demonstrating accountability in community. So when I'm going to community and I'm talking about the importance of clinical research, or when I'm going to community and I'm talking about the importance of our inclusion in a representative population, that I would talk from a very personal and informed space. And so I got my first injection at the end of August. I got my second injection in the beginning of October. This is what we call double blinded. I don't know whether or not I received placebo or the active vaccine candidate, nor does the researcher know whether or not I received placebo. So meaning something that's inert, it's not the vaccine itself or what I received. I can tell you the first injection felt like when I got my flu shot, or better yet, even tetanus. There was pain and tenderness at the injection site, but that was something that went away after a couple of days. It didn't interfere with my activities of daily living. And I can share that after I got my second injection, I did feel rapid onset of fatigue. I was in my car en route to, we have one in-person Shabbat service at my church where we take all the precautions, we're physically distanced, we have plexiglass, we take temperatures and things of that nature. And I was so overwhelmed with fatigue, I could not get out of the car. And I remember feeling that way and having a lingering headache for greater than 24 hours, but fatigue gone within 24, headache within 36 hours. So that's what my experience has been like. And I think it's important for community to hear me, to hear how I've been impacted, knowing my role as a physician, knowing my role as a hospital administrator, knowing my lived experience as a daughter of someone who lost their life, a sister of someone who's still struggling to recover, and as a participant in a COVID-19 vaccine trial.
Can you speak to what was your emotional reaction when you had the first shot seemed fine, you know, little tenderness, that's normal for a shot. The second shot, you said fatigue, headache. How did you respond emotionally to what was happening to you physically? What was your thought at that point?
I was prepared. I was prepared because there was already within the press stories about persons having like a 24-hour reaction after the second administration. And like I said, I don't know what I received. And I was prepared that perhaps something similar could happen to me, but it wasn't so alarming, meaning it wasn't persistent, and it wasn't to the fact that I needed to be hospitalized or I needed to be evaluated. So for me, it was within proportion to what I had signed up for. I saw this as my way of doing battle, as service, as duty, and it wasn't out of proportion for me. And like I said, I'm in a faith-based community, so I have folks praying for me, and I'm a physician and I understand the science. And I was out the next day at a task force meeting, giving public testimony and doing questions. So it was not out of proportion to what I had signed up for.
The reason I asked the question about how you felt about it, because if people hear this information, oh, she got sick or this thing happened, it may make some folks less likely to get involved. But it seems like you said it was proportionate to what you expected. It wasn't an adverse reaction. It was just,
it didn't last longer, like I said, than 24 hours. And so I was able to resume my activities of daily living as we explain it. And so that I think is also important for people to understand. And so it felt like, oh, this is bearable. This is tolerable.
Mm-hmm. And that may happen when a vaccine product becomes available, that there may be some mild adverse, because it happens with like a flu shot. A person can get a flu shot and have similar symptoms, or other vaccinations may produce similar effects. Dr. Balani, I know in the last couple of weeks, there's been great acclaim to the two studies that have shown some efficacy. And when we say efficacy, for those who don't work in public health, we mean like it works, it's effective. So it shows some efficacy for these two vaccine products. Can you tell us what that means for the community and for the people who are listening on the webinar today?
So I'll actually start by regarding what are we looking at when we're giving a vaccine. So when we're looking at the vaccine, we're looking at the primary endpoint and secondary endpoints that's going to come around with it. So the primary endpoint is going to be, first is safety. First is always safety. We need to make sure the vaccine is safe. It's safe on the people. It's safe on the outcomes. It's safe related to long-term, down the road, long-term outcomes of this particular vaccine. And the second part, obviously, is the efficacy in this particular pandemic. With the efficacy meaning, what is the chance of preventing infections in the patients who've taken the vaccine versus those who are under placebo, which, as Dr. Purnell said, placebo means something that's inert, or it's a vaccine that doesn't have the same competence, or it's an agent that does not have the same competence as what the vaccine drug has. So what is the difference in the number of patients who turn positive in the placebo arm versus the vaccine arm? You want to have a result where the placebo arms have the actual disease process and the vaccine arm does not. So that's the safety efficacy of these things. Just remember, this particular virus, this particular vaccine may not just prevent the disease, it may also prevent the severity of the disease. So the two prongs to efficacy is, one, prevention of this particular disease happening in your body if you take the vaccine. And number two, if you do develop the disease, what is the chances that it is not going to be as severe as it would normally have been in patients? So in patients who are at high risk, I think even if you develop it and if you have the secondary efficacy endpoint, that'll make a big impact on the outcome of this particular disease process and the spectrum of this disease process in this area. So both of those. And then, of course, as I mentioned before, is the safety, right? So safety is going to be both immediate safety, which is you take the vaccine, as Dr. Purnell was saying, you're going to have some local reactogenicity to this particular vaccine. But that reactogenicity should be tolerable, right? So if you have something which is mild fatigue, tetanus-like shot, or flu-like symptoms, or fatigue and tiredness or headaches, which last for a couple of days and is manageable. So if it's a mild disease or if it's a mild to moderate disease that is still not impacting your activities of daily living, that is a safety and reactogenicity we're looking for. And then the second part of the safety is obviously long-term safety. So with the requirements that the CDC has put in for the emergency use authorizations, you have to have at least 2 months worth of data after taking the second shot. So it's one, you take the shot again a month down the road. You have to wait for 2 months thereafter to be able to be sure that there's no new adverse event that comes along, that's no new side effect that comes along for the safety paramount before the drug company can apply for an emergency use authorization. So that's part of the safety that needs to be looked at. And of course, once it does come along, once it is used, well, it is used a little bit more widely, the next part of it, which the vaccine trial goes on for 2 years, is to make sure that post-vaccination, that safety data is continued to be collected over a period of time, because some things may not happen upfront. Some things may be very rare. And once you actually deploy it to thousands of people, you may be able to see something down the road, downstream, which is still very, very important to collect and reassess to make sure that that particular vaccine is safe over time. So both of those actions are required.
May I add something briefly to that? I just wanted so people to have awareness of it. Also, as a participant in the trial, you have frequent access to the study team. And when I say by frequent access, especially in the weeks after you get your injections, there is an app that I have on my phone, and the app will ask me questions every morning. Will ask me to take my temperature, will ask me if I have pain, if I have swelling, if I have redness, if I have fever, I have chills. I never developed fever and I never developed chills after either of my injections. I think it's important for people to understand that. And in addition to the app communicating with me, the study team would text, the study team would call, and subsequent to both of my injections, I've gone in for in-person physical review. And so you're closely monitored. Safety is of the utmost throughout the trial. And I think it's important for the public, because this is happening at such a rapid pace that I think it has left people really startled. Like, wait, is this okay to be happening at this rapid pace? And the one thing that I do want to just say about that is the fact that we have thousands upon thousands of persons enrolled allows these trials to happen at a quicker pace than would we normally see. So for instance, Moderna reached its goal of 30,000, Pfizer around 44,000, J&J or Johnson & Johnson is looking to enroll, I believe, upwards of 60,000. So because we have such a large number, we're able to say if there were going to be an adverse medical event, it would surface because you have so many people who've been exposed to it. And so I just wanted to add that.
And let me also actually add one more piece of information that you actually asked, Dr. Reverend Johnson, is regarding the third prong. We talked about safety. We talked about the vaccine effectiveness by trying to decrease the number of cases and then try and decrease the severity of cases. But the third prong of this particular vaccine trial is also the immunogenicity. What does that mean? So it is basically trying to find out whether once you take a vaccine, what is the body's response to the vaccine? You want to see a vaccine's response with a very high antibody level against a neutralizing antibody, which is basically, you want to have that particular body's response, body's host response develop that's going to fight and block the virus from entering your body and infecting your body. So that particular neutralizing antibody level has to be looked at and has to be measured at relative at various intervals over the period of time. So we do that at baseline, and then patients and participants come in on regular visits throughout the 2 years course. So they come in the first time, they come in for the second shot, they have blood work drawn at baseline, they have blood work drawn at the second shot, they have blood work done at frequent intervals during the course of treatment to make sure that we collect the data to find out what is the immunogenicity of this particular vaccine. Was your body able to form an antibody response? If it was able to form the antibody response, what was the titer level? What was the height of that particular response? How long was it sustained for? Because that's going to be important to find out whether this particular vaccine is something that's going to work for 3 months, it's going to work for 3 years, it's going to work lifelong, it's not going to work at all. So all of those information is also inputted through this particular clinical trial. So with the safety data, we did know that after the second shot of vaccine, 100% of the patients actually developed the antibody response. And that data was, as Dr. Purnell was saying, came out very early on. It came out in May. It came out in this after the, this phase 2 studies came out. So it was very hopeful that these antibody responses that are being so robustly formed in the body after the second shot, that you would have a very good success level. But to see how long it lays for, that's where the continuity of care and continuity of the trial with regular in-person visits, not just telephone visits, but in-person visits for blood draws, et cetera, would be required for the immunogenicity follow-ups. So that's going to be very important to know also.
Can you speak specifically to the data? One trial said it was 90% effective. The other one said it was about 94.5 or 8 or so effective. Can you speak to that and what that means in the trial process, and also the likelihood of when a product might arrive?
So when we're looking at the efficacy, as mentioned before, we're trying to see what is how many number of patients were identified in the placebo versus the vaccine arm. So in both the trials with the 90+% of efficacy, what we found was that, for example, the 95% of the Moderna ones, right? So we found that there were 95 cases out of the 95 cases, 90 of them occurred in the placebo arm, and only 5 of them occurred in the vaccine arm, making a big difference in the rift of, yes, the vaccine is effective in preventing it. And then not only that, a very similar thing with the Pfizer, with the activity of being nearly 90+% of being efficacious. So the number of cases that were identified in both of these study arms were mostly in the placebo arm rather than the vaccine arm. And amongst those patients who occurred in the severe high-risk mortality disease status were all occurring only in the placebo arm and 0 in the vaccine arm. So showing that not only was it preventable with this particular vaccine, the severity definitely was markedly different. And not only did that come up, but the subgroup analysis was also very interesting and very hopeful for us, that particular effect was not just in the healthy, robust individual. It was also seen in the elderly population. It was also seen in the high-risk stratification populations where they have other comorbid conditions, where they also saw the same positive impact of prevention that occurred in these cases. So all these particular positive numbers basically leads to the fact that a set guidelines was made that if you meet 151 cases in the Moderna trial, for example, if you meet 151 cases, which is the interim analysis that the data safety board monitoring people are looking at, that would kind of relate that, okay, you've met your mark of being efficacious. To be efficacious, we wanted a 50% mark. We are way past that 50% mark. To be able to apply for emergency use authorization. We've heard, never before this March and this June have we heard the use of EUA in the media, but now everybody knows what an EUA is. EUA is Emergency Drug Use Authorization, where given the pandemic, given the severity of the pandemic that's affecting the world, specifically US here, the modality, the different NIH, the CDC, et cetera, the FDA have looked at various different medications that's available or vaccines that's available or any kind of therapeutics that are available, be it testing for all I care, but any kind of modality that's going to be helpful in this particular pandemic spread is being looked at. And for vaccines, it was that it has to reach a mark of 50%. Once it reached a 50% mark of efficacy, that would be enough to actually enroll it out into the public. So with not just 50%, it reached 90+% in these particular vaccines arm to be able to apply for the emergency use authorizations. Once it applies for the EUA, then another set of board of advisory committees are going to relook again at the safety and efficacy, and then come up with an independent decision whether that particular vaccine is going to be available out into the public. When are we going to be expecting that? I think Pfizer has already applied for EUA yesterday. So that's amazing. It usually takes, I would say, on an average about 3 to 4 weeks for that particular EUA to be looked at and addressed at the CDC site, at the FDA site, to make sure that the data is robust, the data is clean, the data is transparent. It will be available on public sites for people to be able to also access it, approve of it. And once it does, hopefully it'll be a Christmas present to us.
Mm-hmm.
And can I add just one other thing to what Dr. Balani said too? I think really important points for us to discuss. As that data goes through that very extensive review, there are groups who have stood up and come forward well aware of the skepticism and specific to the distrust or broken trust in Black and Brown communities. Like for instance, the National Medical Association, the NMA, historically association of Black physicians and physician scientists who have come out in the press saying we would like to have access to the data so that we can review and translate what the data has shown to our communities. So many of us across public health and many of us across healthcare recognize the need for what we're doing here today, trusted messengers who can speak forth to the broader public about the science, about the data. And the need to do that is because of the level of misinformation and disinformation that we've experienced. So I just wanted to add that. And then one other point, as we go through we meaning the country goes through this EUA process, and Pfizer is first up to bat with that, we begin to think about who the priority populations are that would receive access to that first tranche of doses of the vaccine as they become available. So we're thinking about healthcare workers in certain roles. Then you begin to think about those in high risk or vulnerable populations, the elderly. And as Dr. Balani was saying, it's not projected into the spring or thereabouts that the broader public would have access to it, but just wanted to manage some expectations around that.
And I actually would also just, going back to your first question regarding, the vaccine and how does it work, I do want to make sure that the public is aware that this particular vaccine is not a live virus vaccine. We've heard so many times regarding this mistrust, distrust, and I think it's very, very important to point out that this particular vaccine is not a live virus. You will not be able to get the disease by taking the vaccine. Many of the patients
means that some form of the vaccine and some form of the virus in the vaccine.
Correct. It is.
Skepticism people have that, they're going to give me the virus.
Correct.
From getting the virus.
Correct. And it is we assume that everybody knows it, but if we don't have that particular foundation laid out, it just increases the mistrust that kind of plays over it. So I think it's very, very important to make sure that everybody is aware that this particular vaccine, or both of these vaccines, these novel vaccines, are novel in a way because this is the first time that these particular technologies has been used, where the vaccine's messenger RNA, which is a part of a genetic code that encodes for this particular antibody that we talked about before, is made by the body. So you inject this particular small genetic code into the body, and we expect the body to make antibody immune response to it. And that particular agent that we are putting in is just a messenger genetic code. It is not the virus. You will not get the infection from it. You will just develop the antibodies against the virus.
And one other thing, just to add to that, because I heard this in community, it came up a lot. So as Dr. Balani was saying, it's not a live virus, it's not a killed virus, and the messenger RNA that used does not alter your DNA. So
Correct.
I would hear people in community, oh, you're injecting something into people's body that's going to alter their DNA. That is not what this technology is. And so it's very important when we hear those things in community, because then they take on a life of their own. And you know how the game of telephone goes. When one person says something, by the time it gets to the 100th or the 1,000th person, it's even more different than how it originated. So I just wanted us to repeat.
Tell me about it.
True as well.
I want to get practical for a moment here. I mean, all of this information has been practical, but it's been really focused on the research process. What do each of you say to folks in your communities right now? You know, the holidays are coming up. What recommendations would you make to people to stay as safe as they can be as we look toward Thanksgiving next week, you know, Christmas and winter holidays coming up after that? As a pastor, as research professionals, medical professionals, what do you say to folks in communities that have been suffering under COVID fatigue, you know, for 11 months or however long now? And the holidays are really important to them because this is the, you know, they have those associations of being with mama and grandma and, you know, young ones in the family who are opening presents for the first time, or whatever your holiday, however you experience the holidays. What are your recommendations for community, for best community practices for public health?
I would say, if you all don't mind me jumping in, I would say that the best way to show your love for members of your family, for members of your community, is to stay put. My mother, who I know is watching this broadcast now, hi mom, because and my sister is watching because they wanted to get the information about the vaccine and what have you, because they have a lot of questions for me. I don't have the answers. So I simply suggested, well, you know, watch the panel. The best way to really show the type of love that we profess to have for those in our families and those around us is to love them enough to stay put where you are. Through this same medium, through Zoom, through FaceTime, we can connect with those in whom we love. You can actually celebrate Thanksgiving without there being a festive board spread with your entire family there. Mm-hmm. After the year we have had, why not gather as a family on a Zoom or through FaceTime? Just going around sharing the things that we are being thankful for. There's one collective thing that we all should be thankful for, that we're still here. That for whatever reason, God, our creator, Yahweh, has extended these cords of existence for us. Mm-hmm. And that's enough to still celebrate Thanksgiving. But you don't have to wear yourself out physically, putting all those pies in the oven, this ham, that turkey, as much as I would appreciate it. No, what matters most is we value what is community independent of gathering. Is there still community without us gathering collectively? Of course it is. Yes. Of course it is. There's a cloud of witnesses that are always watching our every move. We are never alone. That thing that we believe that moves from heart to heart and breast to breast. All of us are in different locations right now, but in a very real sense, I feel that we are all in the same room because we're moving toward the same purpose. And that is the total liberation for marginalized people in the midst of this pandemic. So don't tell me you love me and you showing up at my house, looking for some ham. Number one, I'm not cooking. Number two, if you're going to bring something, leave it outside. And once I get a sense that, it's okay, I'll get it. But no, I'm joking. I'm being facetious. But very seriously, this speaks to what Black people believe regarding the collective. Something happens when we get together. And that's a very important and therapeutic component of our development as we seek to work through and sift through the white supremacy we are exposed to each and every day. It's something about when we all get together with red cups, fellowshipping in whatever festive way you fellowship with your red cups in your family. It's something about that. It's cultural. And it's not even about, honestly, about the first Thanksgiving at Plymouth. It's not even for us. To us, the macaroni and cheese is more important than the turkey.
Say it. You did say it.
You know what I'm saying? So, but let's figure out a way of how, if we do this right this year, we can really celebrate together next year.
Right. And I would like to add to that also, you know, when we talked about the social determinants of why one particular center got worse than the others, right? So this vulnerability of infection or more severe disease in the Black and the brown population probably also has got to do with a close contact with a crowded environment, as we talked about, and also the fact that it is our culture. Being Indian, it's the same culture, right? We have multi-generational families living with us. Mm-hmm. Not everybody's health is in the same boat as yours. This particular Thanksgiving or any of these holidays that are coming along, unfortunately, you have to live for them. It's not just your Thanksgiving, it's Thanksgiving that they are around for you. And by staying at home, by staying in your and celebrating in your own living household. So anybody who comes in from outside your family, even though it may be your child coming from the college or whatever it may be, if they're not living in your household, please stay away or keep that child away. To be able to have that multi-generational family living forever. We saw a lot of deaths in each family. We saw moms right now in the hospital. I have a son, I have a father, I have a sister who are striving to live. Hopefully, you know, my sister sent me a small picture in the morning that she said, Zoom Thanksgiving is better than ICU Christmas.
Yes.
I think it's absolutely profound. And if we can stay at home, we can stay with our loved ones at home. We can celebrate with an intent to have that secondary fallout not happen. Please stay at home.
Right. And I'll just second and third what both of our panelists have said. Yes, this is hard. This would be my family's first Thanksgiving without my father and my mother. We lost my mother to Parkinson's disease over 2 years ago. So this would have been a time to get together and to celebrate, since we weren't able to celebrate my father's life, but it's too risky, right? So we're not mixing households. We're not going to have my mom's 83-year-old big sister as a part of our Thanksgiving celebration. She's going to stay in the nuclear household that she's been living in through this pandemic. And yes, that's difficult, but we can find ways. We've mentioned virtual ways, we've mentioned the telephone, of making that emotional and spiritual connection. And then people have gotten creative in some warmer climates. People are eating outdoors, physically distanced, not having multiple plates that everyone would share share meals out of dishes from. But for most of us, I said this earlier this morning, I'll say it again, hold the line. Just hold the line. Hold the line through these next few months, because a day is going to come. You know, because this is a faith-based community, there's a scripture that says weeping, you know, it talks about weeping enduring for the night, but it talks about joy coming in the morning. And our morning is coming. Our morning is coming, and not morning, MOURNING, but our morning as in the brightness, the sun. And that will come, but we have to be faithful to hold the line in the things that we know to be true and to keep us protected. So I recognize and I see people, I say it's difficult. I have a birthday and it's Thanksgiving, and my family were like, well, can we do this? Can we do that? And so I've heard the analogy about the Thanksgiving and then the Christmas ICU, and I want to prevent other families from experiencing what I experienced with my dad, or what I've experienced with my older sister, who is the long hauler. So just hold the line.
And just to kind of reiterate the things that we need to do is obviously social distancing, 6 feet apart. Cover your mouth, your nose. When you're wearing a mask, please cover your nose and your mouth. Don't forget your nose. You don't have to have the mask below your nose. Wash your hands regularly, wash them for 20 seconds, use a sanitizer if you don't have things. Avoid crowded places. If you are going to have it indoors, try outdoors as much as possible. It is getting cold here in New Jersey. But if you are going to have it outdoors, have it in tents, try and keep the sides open, try and open the bottom half or at least a foot or two from the bottom of the tights, tent set, the side walls. If you are going to be doing it indoors, please make sure that you have some ventilation, cross ventilation to try and help, decrease this particular infection from spreading. And as much as possible, stay at home.
I'm going to jump in for a second. Go ahead.
I was going to say, what about the role of testing? I did a wedding maybe a month and a half ago. It was all outside, but there were, it was multi-generational. There were only 40 people. There was immediate family, but there was an 80-something-year-old grandmother, and there were two young women two sisters who were pregnant, and everyone in between. The family required that everyone who was coming to the wedding get tested. And I think testing is another way that could be another tool.
Testing is great. Testing is absolutely great. But remember, testing is cross-sectional. It'll tell you the data of that particular day. It doesn't tell you what happens or what is going to happen in the incubation period, which is from 2 to 14 days. So if you got tested, you got tested on Monday, you got the results on Tuesday, you came and you drove down or you flew down or whatever you did, you came down on a Thursday to have your dinner, and then come Friday, you got sick. Unfortunately, you spread the disease on Thursday. So testing is great, and testing should be done. And testing should be done. If you're sick, please test, please contact, trace, and test, because that's absolutely essential in knowing what is wrong. But testing is literally at that particular time, at that particular day. And again, each test is not 100%. Each test has a false negative. So you really have to be careful in saying that somehow testing gives you a false belief, saying that you're going to be okay or you're okay and you can't transmit. That is wrong. Incubation period is from 2 to 14 days. The testing is just for that particular time point. So testing is great, but it's not 100%.
Thank you. Reverend Williamson, you were going to say something.
Yeah, I was just going to jump in. We have about 5 minutes left. This has been rich, and I know we could go on and on, but Dr. Purnell's got a birthday party to get to, so we don't want to take up any excess of time. But I do want to ask Diane. She, of course, is the director of Christian Ed here at Mother Zion. There were a couple of questions that came through. Some of them came through on the chat, and thank you, Dr. Purnell, for answering some of them in terms of percentages, in terms of how those numbers look. But I think I actually wanted, Diane, especially the one on the math.
Q&A, yes. One question coming in from Chloe Jones. She wants to know, is there really a significant difference in a transmission between cloth masks and disposable masks? And is COVID a strand of SARS?
So cloth masks, which have more than 3 ply, are probably very good. Are they at health grade with what we get in the hospitals? Probably not. There are newer masks. There are newer filters that have kind of always, remember, this pandemic has been a complete innovative fields. Like there are new things that are coming around. And is there a possibility there's going to be a mask that's going to be at par to the cloth, to the surgical mask? Probably, maybe, hopefully. But at the current time, I think still, if you are a healthcare worker, we do recommend you to please wear surgical masks, because there's data on the proof of what works and what doesn't. And cloth masks don't have the same standardizations.
Right. And I was just going to pretty much say the same thing. When I'm in the hospital, I always have on the surgical mask. When I'm out in public, I tend to have a surgical mask, but oftentimes I also have a cloth mask. I'm looking at the amount of layers, but more importantly, I'm practicing physical distancing. I'm not in environments that are cramped or crowded. I'm in environments where I'm very mindful of ventilation. So I would say that to the broader public, because most people may not have access to surgical grade masks. You can keep yourself safe with a cloth mask, as well as everyone wearing it. So universal masking works. But also, in addition to universal masking, make sure you are practicing physical distancing. Make sure you're not in cramped, crowded spaces where there is no ventilation, and make sure you're doing the hand hygiene. It's so crucial. All of those things together will keep you as safe as you possibly could be.
And getting a vaccine does not negate those things.
No,
getting the vaccine is just a part of the health system. Masking is probably going to be the most important. Social distance is going to be the most important piece.
Okay. Thank you. Another question, will the same protocol be followed once the vaccine is distributed universally?
Regarding the safety and efficacy? Regarding the safety and follow-ups?
Yes, the follow-up. I'm thinking, yes, because that question came when you were talking.
Right. So probably not as rigorous as what the clinical trials are, and that's why the trials is different than what the real standard is. But definitely, I think it is an EUA. When you have an EUA, you still are responsible in gathering data and reporting back to the government, to the state. So this particular EUA is going to be no different than the others. So there is a very rigorous follow through that needs to be done with any emergency use authorization vaccine and drugs. Will it be exactly the same as what it was? Probably not. There's no blood draws, etc. that's going to be done with this. But I think it is also the civic responsibility of the person who takes it to pick up the phone and call back the provider and say, hey, I have this X, Y, and Z symptom. So that your responsibility as taking the vaccine is also a big part of it.
And it's important for people to also know that when the vaccine becomes available, let's say it does become available, begins to become available to the broader public in the spring, we still have persons like myself who are part of the vaccine trial, and we're still being monitored.
Okay.
So we'll still have that level of safety information that's coming through across all 30,000 participants for my trial and the upwards of thousands of participants across the United States for the other trials that are being done.
And just to kind of make it forward, that based upon data from participants like Dr. Purnell is what will actually lead to the EUA being switched to the actual licensure of the drug. So the licensure is not the same as the EUA. For the licensure, you need to have your phase 3 data completed to be able to get the final approval process. And that will happen based upon all these 30 plus, well, more than 100,000 patients amongst all these different vaccine trials to actually get the licensure for that particular process.
Mm-hmm. So I have another question, my question. So with so many trials and so many versions of the vaccine being created or out there for us, or options, should we wait for a particular vaccine? You know, should we take the Pfizer or the Oxford? Which, you know, should we wait for any particular vaccine company to get their items out to us?
I say the safety is the utmost priority. And as the data becomes available around what is safe and what is effective, that is the vaccine that the public should say, this is the vaccine that I will take. There isn't a particular brand, there isn't a particular firm or company that's putting out a vaccine. We have other trials that are going on across the United States and across the globe. And so I think it's going to be very important that as that science declares itself, that the public can trust the science that's coming down the pipeline.
I agree.
Thank you. Thank you so very much. This really is Christian education. This really is education. And so this Mother Zion has always been known for this, and we will continue to provide information for you that is helpful, but that is also very, very much knowledgeable and based in fact and research. I think that's welcome in this time that what the season we've gone through. I think it's more than welcome, and we will certainly be continuing to provide that for you. Thank you, Reverend Johnson, Bertram,
Yes.
and Dr. Purnell, we are so very grateful for the time that you spent with us. And Dr. Belani, it's really been a pleasure. And your passion, both of you, your passion connected with your knowledge has just been so refreshing. And we are so very grateful. Dr. Bird, if you would close us out, we are so grateful for you just kind of allowing us to be who we are and not trying to micromanage, but making sure that, right? Yeah. Not at all micromanaging, but making sure that we're providing to the community what needs to be provided in the way in which Mother Zion has always done it. So thank you. Please close us out.
Yes. We have been so very blessed in our congregation that we have such thoughtful and intelligent people who are always at the table, who are looking at ways in which to bring the verifiable information to our communities. And our Christian education ministry in our church is one such example. So I'd like to thank you, Reverend Williamson, our Minister for Christian Education, Sister Diane Chappelle, our Director for Christian Education, for coordinating this. This has been truly tremendous. I have learned a great deal today. And thank you to our panelists, our moderator, and to all of you who have joined us on today. Allow me to also say to you, Dr. Purnell, you opting to be involved in this trial is perhaps one of the most selfless things I have seen emerge during this time. And through what you are doing and what thousands of others are doing, I know without a doubt will be saving so many, many lives. And we owe you and the other persons who are in the midst of these trials a great debt of gratitude for you stepping out of your own comfort to ensure that others will be able to have their fathers around a lot longer. That is tremendous. And I don't want us to leave this session without acknowledging that in you.
I agree with that.
Thank you.
Thank you for all the participants who've been a part of this particular vaccine.
Indeed, indeed.
And Dr. Belani, those research physician scientists who are heading these trials, I salute you. I salute you all. This is a very all hands, all hearts, all minds on deck approach, and we each do what we are equipped to do so that we can rescue our communities and we can save lives and prevent disease. So I'm honored to be on the panel. I'm honored to co-labor with all of you in our communities, and I'm honored to be a physician at such a time as now.
Wonderful, thank you.
Thank you for having me.
Let us be dismissed in a brief word of prayer. O Creator, Sustainer, Redeemer, we give you thanks for how you have allowed us to be bound together in the midst of considerable upheaval, unrest, and chaos, and unprecedented illness in our own homes, in our churches, in our faith communities, and in our communities. We know that as our Creator, you know where everything is that would result in the healing and restoration of thy people. So Lord, bring near to us that balm from Gilead, and to bring healing and the accessibility of healing to those whose bodies have historically been used to heal others. Bring to us an understanding that it's all right to opt towards healing. It is all right to lean toward wellness in mind, body, and spirit. Keep us bound together in love, and all those that we love, we leave in your care. For this we pray in thy great and splendid name. Amen.
Amen.
Thank you all.
Amen. Thank you.
Thank you.
And happy
Thank you, everybody.
Thanksgiving. Happy Thanksgiving.
Happy Thanksgiving to everybody.
Thank you so much.
Right here for Thanksgiving.
Take care. Bye-bye.
Thank you.